speakers.
Thank you, Trish. It is my pleasure to introduce two of my colleagues from Northern California. Dr. Peter Van Houten is the Chief Medical Officer at Sierra Family Medical Clinic, a nonprofit corporation located in rural Nevada City, California, which he founded in 1994. In 2004, he has also served as Chief Executive Officer of the corporation. While continuing to practice as a family physician in addition to his administrative duties, Dr. Van Houten has overseen the addition of integrated behavioral health services for clinic patients. Our second speaker is Dr. Michael Johnson. Dr. Johnson is the Behavioral Health Services Director for Sierra Family Medical Clinic. He's been a member of the clinic team at the Community Health Center, which is recognized as a leader in integrated behavioral health movement for 4 years. His 40-plus years of clinical and administrative experience includes extensive work in adult, child, and adolescent psychotherapy with at-risk and underserved populations. He has practiced in small rural settings and large hospital facilities. And again, Peter and Michael, thank you.
Thank you. Well, good afternoon, everybody. This is Peter Van Houten, and I'll start. Actually, I've been doing rural family practice for 31 years, and for the last 11 years, we've had an integrated behavioral health program. When we started integrated behavioral health in our clinic, it was really a little out of desperation. We realized that our county behavioral health program was downsizing, and suddenly we got an influx of patients who were seriously mentally ill or had significant mental health issues, and we really didn't have the training to take care of them. So that sort of got us started down this road of learning how to deal with behavioral health issues in a way that worked seamlessly with the rest of our medical care. Michael, would you like to say a little bit about yourself?
Well, as was pointed out, I have quite a few years of experience, primarily in mental health as a psychotherapist and as an administrator at Kaiser for about 20 years. And I'm pretty familiar with the integration of medicine and psychiatry. About 5 years ago, Peter and I were discussing his program at a conference where he was a mentor for me, and he asked me if I wanted to jump ship at that time, and I got out of my third retirement to come back. I often say that this is the best job I've ever had, and I really enjoy what I do here.
And we can have our next slide. Well, what is integrated behavioral health care? I think a real short answer is that when a patient comes to your medical setting, that there's really no wrong door for the patient to enter behavioral health services. They can come asking for behavioral health services from one of your therapists. They can start by talking to one of your medical providers. They can come seeking substance use treatment. They can even talk to your dentist if you have a dental program, or they can come seeking pain management. So we've really tried to develop a no wrong door approach to behavioral health, that you can access it from any one of those different arenas. And what we've also tried to do is create a stigma-free environment where behavioral health is considered just like treating diabetes or any other physical problem. And I know when we first started, there was this sense when patients would come in and they were here to see one of our behaviorists, one of our therapists, that there'd be some embarrassment, or they'd be worried what other people would think. Certainly when people would have to deal with the behavioral health department in Nevada County, many people wouldn't even park in the parking lot because they were worried that someone would see their car in front of the county behavioral health department and would think of them as crazy. And really there's been a huge shift for us over the last 10 years that now people are very excited to see our therapists and our telepsychiatrists that we work with regularly. And this whole idea of stigma has really shifted completely, where now people, all our patients, see that behavioral health is a key part of their everyday health care. In fact, sometimes we'll have patients that are seen by medicine, by a medical provider, by behavioral health, and in our dental unit all in the same day. So that we've actually integrated healthcare across all those spectrums. Next slide. We've really tried to work with the idea of a medical home, and I think the best way to conceptualize of how practically an integrated program works is that your behaviorists and medical people work together real time. This is not something where once a week you all get together and talk for 2 hours about all your patients. Most of what we do happens real time while we're seeing the patients. If Michael has a question for me about a patient that he's seeing, he comes and finds me, interrupts me, and vice versa. If I'm having trouble with a patient and need his input, I go find him. So much of what we do really happens at the level of a curbside consult. One of the things that we've found is that it dramatically improves the quality of care for our patients if we include what's in their head in addition to the rest of their body. You find many people in medicine are still sort of practicing medicine from the neck down, and we've found that adding therapists into our program, that suddenly we're finding out why some people aren't getting well, because we haven't been addressing their behavioral health issues, which were really more at the core of what was happening with them. So we really try to learn from each other. In fact, I feel like the real ideal environment in an integrated behavioral health program is that the therapists and the medical providers work together as a team and learn from each other. Mike?
Well, also, our program also contributed to and was born out of a project in California that was very, very successful, I believe, and it's called Integrated Behavioral Health Project. And I put the website up there for you to look at, www.ibhp, And the reason that I think that this is a good website for folks to look at is it has a number of tools, and it also has a toolkit section. Later on, as we're discussing, for instance, screens and evaluation and tracking and forms and things started with, it's an excellent website that has lots of information and can steer you in very good directions with lots of good dialogue, and they're still going strong, as a matter of fact.
Our next slide. Just a brief history about our clinic so you know a little bit more about us. We actually opened in 1982. We literally moved a backhoe out of an agricultural storage shed and moved us in, and gradually grew until 1997, till we built the clinic that you can see in the slide here. We added behavioral health in 2002. In 2004, we added dental. In 2008, we added a substance use treatment program. And we've done pain management since about 2004, again, all integrated in. Typically, we see about 20,000 patients a year of all types, and we see about 3,500 unduplicated patients, and we're just about ready to add a second site, which is about 35 minutes away. We're actually quite rural. It's about 35 minutes to the nearest town from where we are. But interestingly enough, since we've developed this integrated behavioral health program, about 40% of our patients actually drive over 35 minutes to get to us, because we offer this unique service that people are voting with their feet. They realize that they get a better quality care here, and that has actually allowed us to grow much more robustly. Michael, did you have anything you wanted to add?
Well, and I've worked in both metropolitan, very urban areas, and also worked in semi-rural. I would say that this goes close to frontier in terms of the types of population that we see. Many of the folks have basically dropped out of society in a lot of ways and live in very interesting conditions up here. And I think those of you who work in rural areas have a taste for that kind of special population. It can be very complex. Actually, a lot of issues regarding especially in behavioral health, how you do confidentiality issues and things like that can be very challenging in small communities. Basically, we'll probably touch more on population-specific issues later.
And our next slide. Well, why integrate behavioral health and primary care? Well, I think a good way to summarize it as a physician is to say it solves the reaching for the door handle syndrome. Well, what do I mean by that? I mean, a typical visit for me 15 years ago is I would be finishing up with a diabetic patient. I'd ask them if they had any final questions about their medical management, if they needed any refills. I felt like the visit had completely come to an end. I shook their hand. I turned around, and I was reaching for the door handle, at which point they'd say, you know, I didn't mention it, but I can't sleep. Or I really didn't say anything about this, but, you know, I've been really depressed. Is that something I should be concerned about? And this happened to me so often that I realized that there had to be some way for us to get ahead of the curve with patients where we were addressing what were really key issues for patients at the beginning of the visit. Next slide. You know, many medical providers have asked me, well, I just can't consider adding one more thing to what I do. I feel like I'm already overloaded. You're asking me to add in one more type of patient, and I'm going to have to deal with a therapist now, and I don't have any extra time. Well, actually, Kaiser studied this. What happened with their medical providers when they added an integrated behavioral health program? And basically what they found, and this was our finding as well, is you end up saving about 10% of the primary care provider's time by having a behavioral health therapist working along with you, because you end up handing off things that are appropriate for the therapist to the therapist and don't have to deal with those as completely yourself. You just need to initiate the contact. And secondly, a lot of your patients that were frequent flyers or would come back with vague complaints that you could never completely evaluate or analyze or come to a solution with, suddenly those patients were getting the appropriate kind of evaluation, which was really more with our therapists. And that's basically what we found, is that many of our patients really wouldn't get well until behavioral health was involved. The other thing is that we found that there's been a tremendous increase in patient satisfaction because people feel that every aspect of their health care is being addressed at every visit, and that we have the capability of addressing mind, body, and spirit all in one place. One other thing that integrated behavioral health has done for us, I go back 15 years, and it was not uncommon with our patients that we were treating for any kind of pain syndromes or pain management. Friday afternoons were the argument afternoon, where we start getting people calling us arguing that they needed more pain medication or they were leaving town. It was always kind of a mess, and since we've had a behavioral health program where our pain management has been integrated in with our behavioral health management, the era of arguments about medication has really gone away. So, Michael, do you have any comments you'd like to add?
Well, no, next slide, I think.
Okay. Good. Well, one of the things we did when we first started with a behavioral health program, this was 11 years ago, and we felt we were actually doing a fairly good job of identifying among our patients who was depressed, who was anxious, who needed some sort of pharmacologic treatment. And we actually, as part of a study, tested every single adult that came in the door and tested them for depression, anxiety, a whole host of things with a written questionnaire. And much to our shock, it turned out that close to 30% of our patients tested depressed, 30% of our patients tested anxious, 8% tested positive for significant alcohol use, 25% had some evidence of panic disorder, and about 20% had some social anxiety disorder. So we were really struck with the shortfall that we had in addressing these key issues. Now, obviously, all those numbers I gave you, add them up, it's much more than 100%. I think a good way to put it would be that over 50% of the patients that we were seeing had some significant mental health issue. And for most of them, we were not addressing it directly. So having the ability to involve a therapist and really go after their behavioral health issue in a way that was very comprehensive really helped. In fact, one of the things we do now is every year, every adult gets a more comprehensive screen for behavioral health issues, but at every single visit, patients get asked 2 depression questions. Have you been feeling depressed or hopeless? Or have you had very little interest or pleasure in doing things? This is just on a little written questionnaire they fill out before they see the medical provider. We ask them if they smoke and how much. We ask them if they drink alcohol and how much. And we ask them if they're feeling anxious. So that's on a little green form we have them fill out before the provider walks in the room. And we've found that, in fact, I've learned it's the first thing I ask for is I greet the patient, shake their hand, and say, where's your green sheet? Because I want to know those things right when I start the visit because I want to make sure I incorporate whatever I've gotten from those questions into our visit. Next slide. You know, many medical providers have asked me how difficult it is to learn to use the psychotropic medications because the truth is many patients are receiving their psychotropic medications from their primary care providers. And I think while most medical providers are at least comfortable with some of the basic SSRI type medications, things like Lexapro, Prozac, there's a much richer psychotropic formulary available to us. And it's quite possible for someone in family practice who's not had great experience with this to gradually over time begin to become quite familiar with these medications and to become more expert at using them. And basically the way I describe this to other providers is that think about this the same way you would when you learn to treat diabetes. Back when you first started, you know, you were probably struggling even to use the oral agents correctly, learning how to balance people's blood sugars, what to watch for. Seemed like there were 10 or 15 different things you were trying to get done on every patient every year, and it all seemed very complicated and overloading. But with any year, you felt much more comfortable and were gradually adding more medications into your comfort zone, things that you would feel comfortable using, better at using insulin, things like that. And I have to say for using the psychotropic medications, it's a very similar process that start right where you're at, and some of the things you can do is to make sure that you really scrutinize any psychiatry consults that you get. You can work closely with your therapist if you have a therapist on site, because often they'll know quite a bit about the psychotropic medications. And definitely there's plenty of continuing medical education that you can get and gradually learn how to become comfortable with these medications. And again, I would just conceptualize it just like when you learned how to treat diabetes from the beginning. It wasn't easy at the start, but now it's sort of second nature. And I'd have to say I feel that about the psychotropic medications. I feel very comfortable with them, but it didn't take me 1 or 2 years to feel that comfortable. It took me several years of really applying myself and learning it, but very rewarding because now I have at least a couple ideas of how to work with virtually any patient that I see, and then can still ask for help if I'm stuck with a patient. Michael?
Just on that last note where it says 90% of elderly patients receive mental health care from their primary care, as a trained gerontologist, we know that about 60 to 70% of that population as well take benzodiazepines. And it often they're dealing with anxiety and depression, and they come to their primary care physician actually to receive their counseling at times. and we found that having behavioral health in the same, basically next door, right in the same office, helps in terms of addressing their needs. And I find myself now with probably about 20 to 25% of my caseload being in the over 65 to over 70 population. Next slide, please. We also know that the issues of emotional disorders are factors in health and compliance and levels of healthcare literacy. So what do I mean by that? A lot of people might say, well, my blood sugars are out of control, and I don't know what to do. They'll say that to their primary care. And the primary care will say, well, are you taking care of yourself? And they'll say, no, I forgot, or I'm too depressed, or somebody needs to show me how to do this, and so the primary care physician will get, the provider will get very frustrated and not know what to do and say, well, you need to know this, you need to know that. If you have an integrated program, that person can be handed off directly to the individual, to the behavioral health specialist that minute, that second. Levels of healthcare literacy, what do we know by that? Oftentimes I'll ask people, well, you're on about 6 medications. Do you know what they're for? No, my doctor gave them to me. I trust him. I trust her. She's a very nice person. Well, do you know what diabetes is? Not really. Do you know what hypertension, hyperlipidemia? And they really don't know. They really don't understand. They have a feeling that they must trust and not ask because asking questions may be impolite. The other thing is, in a rural population, the issue of literacy just means that. We often have people who have hidden the fact that they can't read or understand or write for years, and they still get by. The examples are a lot. I mean, we're going to talk probably a little bit more about diabetes, but we do know that, for instance, stress and depression have a lot to do with the diabetic population. Anxiety has a lot to do with those clients who have respiratory disorders, COPD, anxiety and depression and cardio issues. And you see a lot of cancer patients who are dealing with anxiety and depression about their care, about end-of-life issues and so on. And with the kidney disorders, you often see organic disorders in terms of issues with how they're processing things because of their health, and also the same with different hepatic disorders. So the examples are many, many, many where you find that emotional disorders and actually major mental health diagnoses are involved in the care and the disorder that's going on. Next slide, please. I think it's safe to say in a lot of places that primary care has become the first line of treatment for mental disorders. Those of you who work in busy practices, I think, can identify with this issue, that oftentimes people will come in for one thing, and in the middle of your conversation and your exam, they'll be talking about another. They'll be talking about domestic violence, drug and alcohol abuse, depression, of all sorts of things. And you at that moment, as a provider, may not know where to go with that. You've got 5 or 10 more minutes in your visits. You're behind schedule, and so on and so on. And you soon get impacted. Again, if you have an integrated program, you have a place to go to. You have consultation that's instantaneous and integrated. As Dr. Van Houten pointed out, an integrated setting reduces the stigma of seeking mental health. Many people come to this clinic and they transfer their health care because we have behavioral health. There are many doctors who go to, perhaps in the community, even closer to their home, but they come here because they can get their behavioral health needs met here. The other issue, many of you may or may not know that next month, DSM-6 will come out. This is the Bible for mental health clinicians and psychiatrists. And the new edition shows a shift to behavioral comorbid physical aspects of diagnosis, that they're actually going, well, maybe if a person's depressed, maybe we should look at their health and look at their diabetes issues, look at their thyroid issues, and so on and so on. And this is the first change away from the more just direct line mental health behavioral way of looking at a mental health issue. Next slide, please.
One of the things that's been shown recently is that among the seriously mentally ill population, that they have substantially reduced lifespan. Basically, if you're someone who's seriously mentally ill, you're a type 1 bipolar or schizophrenic, your lifespan is in the early 50s. You're not probably going to live longer than that. If you add substance abuse to that, you're actually down into someone's 40s. And the truth is that many of these individuals are dying from preventable causes. And it's because we've had this separation of behavioral health and primary medical care in our culture that often people don't have their high cholesterol, blood pressure, smoking problem addressed along with their schizophrenia, that they're adequately treated for their mental health disorder in specialty mental health, but they don't get proper primary care. I know one of the things that we've tried to do in our county is to actually bring primary care providers into the mental health department. So we actually have a room there where we can see patients that have the mental health department as their medical home, but we come in to provide primary care services. And it means that we can address things like smoking cessation, alcohol use, also deal with their cholesterol elevations. Things like this are going to substantially shorten their lifespan.
And as I pointed out before, something that's unique perhaps to the rural area, but could also be for inner city clinics. The distress of some of the folks that, let me back up, where people go through a lot of distress in terms of psychosocial issues, psychosocial factors, really affects their health and their at-risk situation. For instance, up here we might, during the winter, have folks who don't have the resources to deal with the heat or having enough heat or having it too cold, or having a homeless population up here is very, very deadly. So many, many factors correspond with morbidity and mortality, and these are all psychosocial factors that oftentimes people become at risk for because of a number of factors in their lives. The other thing I think I want to say is that I've worked in this work for a long time, and I think in the last 10 years I can say that the medical community is much more accepting of integrated care, in the sense of they can see this, they can see these psychosocial factors as things that really affect people's health and their ability to receive and comprehend and be compliant. Next slide, please.
You know, one of the things that we found before we had an integrated program is that when we had a patient we were seeing who, let's say, was depressed, and we felt they would benefit from seeing a therapist in addition to receiving medication from us, and had insurance that would cover a therapist that was reasonably close by to where they lived. And then we looked at how many of those patients actually made it to one visit. Now, these are patients that we referred, they had insurance to cover a visit, and they said they would go. Well, it turned out about 15% actually made it to one visit. So incredibly low number. I mean, it was almost like, why were we bothering? When we had therapists on site, and we did that same model of, oh, you know, I think you'd really benefit from seeing Michael Johnson, our therapist, and here's what I'd love for you to talk with him about, and I think you're going to find that this really helps with the medical management that you and I are doing for your depression. We found about 40% of patients would actually make it to a first visit. And the thing that we developed, because we were still feeling that 40% was a very low number for patients who could really use this kind of help, is we developed what's called the warm handoff. That is, if I'm seeing a patient and I feel they're going to benefit from seeing one of our therapists, we actually notify the therapist that we have a patient who needs to be seen. Literally what we do, we have a little request form that gets slid under the therapist's door. And the therapist actually stops what he's doing with his current client and comes and meets with me and my patient briefly. We call this the warm handoff model. And actually the patient, myself, and the therapist, we all discuss their case very briefly, and suddenly I can leave the room and they continue talking briefly. And we found if we do that model, over 90% of patients make it to a first visit. So we've gone from the 15% having a visit to 90% by really changing how we work. And actually, our dental practitioners refer to our therapists as well, and will invite the therapist to come over and see patients who are having dental phobia, or they realize they have a substance use issue that they've discovered by doing their dental exam. And they use our therapists as well. Next slide, please.
Oh, go ahead. No, that's fine. Go ahead. Back one slide, please. I'm sorry.
Sure.
I apologize. If you see the slide, and if you've been working as a primary care provider in the last 15 years, you know that depending upon the county that you're in, a quarter to three-quarters of the patients that usually were seen by the county are now seen in primary care. And in some frontier counties, this figure is much higher. And some telepsychiatry and some telebehavioral medicine, telebehavioral health fills that gap. I just wanted to point this out because you're seeing a lot more mentally ill folks in your practice, whether you like it or not. In 2002, the counties basically told a lot of their patients to go to primary care, and that's not come back to any kind of normalcy. Next slide, please. Okay. Next slide, please. Hopefully you can see this slide. You know, these are the different models of integration. The one at the very top, of course, is the traditional model where the physician or the primary care provider will refer to my private practice down the road, maybe 10 miles away, and say, go see this guy. He'll really help you out with all your depression and things like this. The desirability of that is very, very low. And this is where Dr. Van Hout was speaking, that you have very, very low turnout in terms of following through. Then there's the one-to-one referral exchange, and there's some back and forth on that where Dr. Van Houten calls me up personally and he says, well, this will help you out. And then there's the co-location and the collaborative care and fully integrated. What we're talking about is the last box, fully integrated primary care team member, where basically my desk is right next to Dr. Van Houten's. Next slide, please. We'll go through this because we want to get to some details. As we said before, we're trying to improve the physical and emotional health of our patients, doing this in one place. We can improve and manage the behavioral health needs of a population in one place. And we also use prevention and wellness strategies, which we'll point out in a few minutes, to prevent the onset of disorder or prevent reoccurrence. Next slide, please.
And actually, one comment that I would just make on this is that this is for our medical providers, is if you're seeing someone who's a diabetic, remember they have a 50% chance of developing depression as part of their diabetes. When a person's blood sugars are elevated, it actually changes blood flow in the brain in a way that predisposes to depression. If someone's had a recent myocardial infarction, you know, they're a post-MI patient, in that year following, it's over 70% chance they're going to get depressed. Someone's had a stroke, there's an over an 80% chance they're going to get depressed in the year following their stroke. So these are all medical issues that have significant psychiatric comorbidities that we need to be alerted to as primary care providers. This is an award we received as world champions for the work we did in integrated behavioral health. Just kind of a fun thing to put in, see that we're real people. Next slide.
Okay, so how does it work? From my standpoint, basically, I'm in the same office as Dr. Van Houten and the other providers, and my visits are usually 15 to 30 minutes in length. Our goal is 10 per day. We usually make between 9 and 14 encounters. And actually what I want to say is the schedule is no longer a schedule. It gets pretty raggedy-andy at times with warm handoffs. The encounters are also vulnerable to interruption. So the behavioral health provider at times has to be in two places at once, and this is actually doable in terms of our schedule. And I'll explain more of that later when we talk about warm handoff. And treatment encompasses the behavioral aspects of the care, like we've already said, chronic physical and mental illness, big pain management program, and also substance abuse. Next slide, please. And the behavioral providers are, of course, LCSWs, psychologists, and nurse practitioners. And within our scope of practice, we need to understand the best we can medical issues, and oftentimes this means a very quick learning curve unless you worked in hospital-based settings or medical-based settings in the past. Now, the interventions can go on and on here, but primarily, I don't want to go through all of them, but you can see that there's trauma, organic disorders of the brain, pain management. We talk about caregiver stress, grief and loss, primary function associated with chronic illness. We see a lot of ill folks that are dealing and struggling every day to get by with quality of life issues. Next slide, please. Also within your scope of practice, the clinician behaviorist must understand psychopharmacology and pharmacology, and associated with issues like psychiatry and pain management. Understand every DSM disorder for all ages and be able to make immediate and secondary diagnoses. You are also asked to make ongoing risk assessments and oftentimes crisis intervention and de-escalation.
And actually, their assistance in crisis intervention is one of the biggest helps that we get from them if we have someone who's acutely grieving or suicidally depressed, that we're able to start with the patient, identify that, and then bring the behaviorist in to help us with that patient and come up with a good solution for them. And trying to deal with a patient that acutely ill would be very difficult for a primary care provider just on their own. Next slide.
From a behavioral health standpoint, interventions included but are not limited to. I'm not going to go through all of these, but show you a few of them. Cognitive behavioral therapy, which works primarily with distortions, the distortions we all have. DBT, which is related to mindfulness. Narrative therapy, imagery, stress reduction, EMDR for acute stress disorder. Mind-body interventions, solution-focused therapy, acceptance, and most important is what we call compassion. In this setting, you have to use what we call intention and attentive intention. In other words, I'm with that person 110% when I'm with them. I'm a big handout person as well. I use a lot of handouts regarding caregiver stress, hypertension, diet, smoking cessation, parent-child issues, and other kinds of things. Next slide, please.
You know, one of the things that I would want to mention just on the warm handoff issue where we try at the primary care visit to bring the behaviorist in to actually meet with the patient is that it turns out most insurances allow patients to have both a medical visit and a behavioral health visit on the same day. So if the behaviorist has time, they can actually expand that warm handoff into a full visit. The other thing that I'd comment on that is that whenever we do this warm handoff procedure, there's always this magic moment where when the patient sees the behaviorist and myself discussing their case in front of them, they suddenly get why it's important for them to see the therapist. And that's part of the reason I think their acceptance rate goes up so much. Next slide.
of a warm handoff, and actually I see a number of questions, and I'm going to try to get those as we speak. First of all, the ratio that we have right now, we've got a little over 1 FTE that we're working with in our clinic for 4 providers. The benefits of a warm handoff from a behavioral health perspective, I don't know, a lot of you that might see this might be psychotherapists and clinicians, and you go in your private practice and you sit and you take an assessment. It takes you an hour and a half. Here, you're hit with a dozen things in 10 seconds. It's intense, it's open, it's honest. These people really want to say what they want to say quickly, and it's oftentimes extremely intense. I find that using a very descriptive and honest language with folks and motivation perspective helps quite a bit. The issue of an appointment in this setting is to get another appointment. That's your goal. Your warm handoff is your goal to get another appointment to do more work. So you have to be extremely flexible. Also, in terms of, I avoid labels. For instance, if somebody's coming in with an obvious alcoholism issue, I'll probably talk to them about their liver rather than their drinking during that first session, but then we'll get into it much more detail. Next handoff, please. Or next, not a warm handoff. Next slide, please. Basically, on the warm handoff, the provider will prep the individual and say, well, as Peter said, we have this person I'd like you to talk to you about your depression today. The provider excuses themselves, comes and gets me. And oftentimes, Dr. Van Houten will give them a screen to fill out. Myself, and we begin a dialogue of what's going on with the patient there and myself, and we all collaborate. And so you see that there's transparency. The client, the patient knows exactly that Peter and I are talking to each other about their case. And I think this does an awful lot for their trust.
Next slide, please. One of the things that we try to make use of is that for the 4 or 5 minutes that we're out of the room getting the therapist, we'll actually have the patient filling out a number of screening questionnaires which give us more information. For example, we use a very general screening questionnaire called the Modified Mini. And again, all these questionnaires are available on that IBHP website that we mentioned, if you'd actually like to see them. We can have them fill that out. We can use the PHQ-9, which is for a depression evaluation. It actually gives you a numerical score that you can track over months to see if a patient's depression is getting better. Certainly, if you're seeing a patient who has depression that you're diagnosing for the first time, particularly if it has any anxiety associated with it, you want to make sure you at least do a mood disorder questionnaire, or what we call the MDQ, which is actually a screen for bipolar disorder. And if this screen is negative, it's very indicative the person is unlikely to have bipolar disorder. If it's positive, they may or may not have bipolar disorder. But if it's negative, it means you probably can safely go ahead and start with an SSRI-type medication for their depression and not run into any problem with throwing them into hypomania. I often will give out the Epworth sleep screen because people complaining of fatigue, that's one thing that often is missed, is sleep apnea, and the Epworth score will do that. And we also have drug and alcohol screens that we do as well. So we have quite a bit of information for the therapist when they walk in so that we're able to really keep our time efficient. Next slide.
The other, I'm sure we were out there. One thing that would like I pointed out in terms of we come back into the room and the behaviorist, I and the patient discuss the screen results, oftentimes with Dr. Van Houten in the same room. And like I pointed out, I'm very straightforward with folks. I try not to also repeat what's been said to them before. and try to look at venues in terms of dealing with their problems. And then Peter comes back in the room if he's not there already, and we all discuss a treatment plan. Next slide, please. We've produced a DVD which depicts a dozen scenarios. A number of these are on YouTube, actually, if you want to go click on these. And these examples include a warm handoff situation with diabetes, post-MI, insomnia, smoking cessation, obesity, and so on. And it shows Dr. Van Houten with a behaviorist and a mock patient going through the process of the warm handoff. It's a very helpful DVD, which I would urge you to look at. Next slide, please.
You know, and Michael, I think I was going to suggest in the few minutes we have left, maybe we can take a few questions.
Okay, go ahead.
Quite a few questions. What are the funding sources?
The funding sources, it's an interesting question. First, let's go back to the FTEs and what we try to. Say again? Oh, the FTEs that were about 1.2 or 1.1 if you put myself and two other providers together. And my goal is to try to get, from a business model standpoint, to 25% revenue. Right now we're at 20, hovering at that point. And so we bring in that revenue into the clinic. Funding sources are through grants as well. And basically, I think we're not quite sure how it's going to work out in terms of the new health plans, but we think that same-day visits will also be funded, which will help us a great deal.
And one of the things that we found from a fiscal standpoint is behaviorists pay for themselves. You know, actually, if you just look at their salaries and any extra expenses that are associated with having a behaviorist, their fees actually cover that. So this is not something you're adding on as a service that's going to be a drag on your facility. This is actually something that's going to pay for itself.
We have a question here. How do you get paid for same-day visits for mental health issues, parentheses, not for health and behavioral codes?
Well, there are a number of codes, actually, and I discovered some of these last week. There are some 15-minute behavioral health codes, and the person that asked that question, if you could give me a phone call, I can dig them up for you. There's actually two CPT codes for behavioral health 15-minute encounters, which we're going to begin to use. Prior to that, we were using the old CPT code for group encounters, which is 15-minute. So there are different types of codes to use, and if you're interested in that, please give me a phone call, and I can discuss those with you. But when the CPT codes got changed over in January, we struggled with that a bit, but we are able to code them properly now.
So the question here is, behavioral health also taxed with providing case management service, or is that a separate department?
Well, we do case management services, but we also have a case manager who's funded through grants through the county and United Behavioral Health. And this individual helps us with other kind of case management and liaison with county services.
And what is the ratio of behavioral health providers to PCPs in our setting?
Yeah, actually, when you first start, it's not unreasonable to have a ratio more in the neighborhood of 6 medical providers to 1 behavioral health specialist. But what most clinics find is that very rapidly that ratio drops down to 1 behaviorist to 3 or 4 medical provider time. Actually, there are clinics that have a 1-to-1 ratio if they have the funding for it. But I think you'll find most clinics that have adopted this model, pretty quickly they settle in to somewhere between 1 therapist for every 3 to 4 medical providers.
Okay, it looks like Tricia is saying that they have to end the webinar at this time.
Okay.
That questions could be emailed to the doctors and answered that way.
Yes, actually, if anything that we were unable to address, feel free to email us. As we've included our emails on the PowerPoint presentation, and you can email either one of us, and we'd be happy to address what we can for you. And this has been great for us to have a chance to speak with everybody today. This has been real really wonderful.
Thank you all.
There's our contact information.